topic, present some kind of practical solutions as to how to start a program in doing this without a tremendous amount of infrastructure support, give you some of the data regarding its efficacy and how these procedures work, and then kind of tell you about some future directions of where we see the field going. I have two non-relevant disclosures. So for an outline of today's lecture, we'll first begin by kind of discussing kind of overall how the lymphatic system works. We'll discuss breast cancer-related lymphedema specifically as it relates to breast cancer. We'll discuss the workup and the multidisciplinary team that most people need to really start a program and work these patients up. We'll discuss the treatment options, and in particular, we'll discuss two main treatment options: preventative lymphedema surgery, or lympha, and two of the vascularized lymph node transfer procedures that are used to correct existing lymphedema. And again, lastly, we'll discuss some future directions. So the lymphatic system is really ubiquitous throughout the system. It mainly concentrates in kind of the popliteal fossa, the groin region, the axillary region, as all of you know. And the lymphatic system acts to pull in interstitial fluid from cellular debris. It transports these via lymphatic capillaries into lymph nodes. This debris is expressed and antigens are presented via T and B cells, and then the rest of the lymphatic fluid is then drained back into the circulatory system. And when there is some kind of injury to a lymph node via radiation or tumor extirpation, it provides for lymph stasis because that lymphedema fluid can no longer go anywhere. So it stays in that interstitial fluid, thereby leading to inflammation. This chronic inflammation leads to proliferation of adipose tissue and fibrosis, which further disrupts lymphatic channels. And you kind of see a vicious cycle which can occur as a result of this. In the United States, at least, we have approximately 5 to 10 million Americans who are affected by lymphedema. The vast majority of these are secondary to some kind of oncologic process or lymph node removal. However, worldwide, about 150 million people are affected, and actually the majority of which are affected next to a parasitic infection, Wartschia bancrofti. We know that it has an extremely negative impact on quality of life, and there's a permanence to this disease as there's no cure. It's simply conservative management, and forever. So with that, we'll discuss a little bit more about breast cancer-related lymphedema. Breast cancer lymphedema is exceptionally common amongst patients who have radiation and axillary dissections. And when we view a meta-analysis of risk factors for the development of breast cancer-related lymphedema, you see an axillary dissection is independently predictive with an odds ratio of up to 6. The greater number of lymph nodes taken in that axillary dissection, typically over 21 or 22. Mastectomy itself is independently predictive of lymphedema formation. Obesity is defined as BMI greater than 30, radiation and chemotherapy. And it's not that hard to see one of your patients who may receive a mastectomy axillary dissection is slightly obese with radiation. These patients have exceptionally high risks of developing lymphedema. And in fact, 1 in 5 women who survive breast cancer will develop breast cancer-related lymphedema. The vast majority of these will develop these symptoms within 3 years. The greatest risk factors are axillary dissection, obesity, and radiation. And if all 3 of these are present, up to 70% chance of developing lymphedema at 1.5 years. So let's talk about the impact of breast cancer-related lymphedema. Well, we know it has a significant decreased quality of life in patients, particularly physical function, body image, social function, and psychological well-being. There's also, at least in the United States, an element of financial toxicity to the disease, and the average patient is spending up to $1,000 out of their own pocket for coverage, largely because treatment is expensive, but also most good treatment centers are confined to larger institutions. And for that reason, patients either need to take off time from work to drive to these longer institutions, or stop working altogether to afford some of these therapies so that they can maintain their therapy. And so it really is a problem for patients, particularly who are young, in the middle of their income producing years. This can be exceptionally burdensome from a financial perspective. So let's talk about the workup and the multidisciplinary team approach that is utilized to really address a patient that has breast cancer related lymphedema. As I said before, this is really a team approach. This involves occupational therapy and physical therapy as the mainstays in treatment when addressing these patients, but also radiology and surgery definitely have a role. But it cannot be understated that prehabilitation with physical therapy is of the utmost importance. Physical therapists and occupational therapists will provide complete decongestive therapy to these patients for at least 6 months before being considered to be full surgical candidates, as to decompress a patient to a baseline. They're helpful with garment sizing. They can troubleshoot malfunctioning pumps, and they are helpful with ensuring compliance because they're seeing patients on a regular basis and can really kind of provide positive feedback. It should be said that compliance with conservative therapy is of the utmost importance. We know that weight loss independently can predict decreased levels of lymphedema. They can be important with, providing the complete decongestive therapy, which involves manual lymphatic drainage, exercise, skincare, and lymphatic massage. And they're also very helpful with fitting custom compressive garments. Physical therapists can also provide assistance with outcome assessment, but most of these outcome assessments can be performed by the surgeon as well. We're going to show a lot of different fancy options by which to evaluate patients with lymphedema, but really some of the most tried and true measures can be done in an office with a measuring tape. This involves circumferential limb measurement, taking at interval lengths across the limb with regular symptom and documentation and accurate measurements. However, there are also other tools such as LDEX, which measures the water content of the arm, pyrometry, which measures volume, and probably more important these days are outcome assessments using quality of life questionnaires. And within lymphedema, there are several well-validated quality of life questionnaires that can be, purchased or borrowed online. This includes the LymphQual and the lymphedema specific quality of life tools, which are the ULL 27, IDI, and LymphQual. Radiology also has a role in working up these patients. Particularly MRI can be helpful when deciding between, does this patient have lymphedema or is this lipedema? Is this fat or is this water? CT angiograms can assist with reverse lymphatic mapping, lymph node basins, and flap dissection. And this is something we'll touch on a little bit later in the talk. Lymph node scintigraphy can be helpful if you're really kind of unsure as to whether or not a patient has lymphedema. And this is done by which technetium is injected distally and you measure transport times between the affected and the unaffected limb. This can also assert with prognosis. And if you are transplanting lymph nodes, it can be helpful to visualize the dye uptake once the lymph node has, taken within the vascular bed to assess, kind of overall outcomes. ICG angiography can be performed in the office or in the operating room. We have tools such as the SPY Elite system, but also there are handheld devices like the Hamamatsu. This can be helpful for assessing for bypass targets, for lymphovenous bypass. It can assess the stage of the disease and can also assist with prognosis. Ultrasound can also be helpful. In a patient with a very scarred axilla, you really want to make sure that the patient does in fact have lymphedema or they don't have some kind of subclavian vein thrombosis. So a simple ultrasound can help assess some of these problems. With regards to staging, there are many different staging systems to assess lymphedema. One of the more subjective stages that pretty much anybody can use is the ISL, or the International Society of Lymphology scale. And in that, stage 0 is latent lymphedema. This is patients who have had an injury to their lymphatic system, don't really have any symptoms yet. And you can see how the scale progresses to a point where stage 3 is full-on elephantitis with end-stage disease with severe skin changes. From a surgical standpoint, One of the more helpful stages is the indeciding green scale, really popularized by the group at MD Anderson, in which stage 0 represents a lymphatic injury, but you can still see when ICG is injected that there are patent lymphatic channels, there is no extravasation of dye within the arm, and that there's no dermal backflow. This goes on to stage 1, 2, 3, and 4, where by stage 1, you start to see some dermal backflow, indicating that the ICG in the lymphatic channels is spreading into the interstitial tissue, thereby demonstrating an injury, but still intact channels. And then you see in stage 4, where there are no intact lymphatic channels, and in fact, all the dye is really spread into the interstitial fluid. From a surgical standpoint, this can be helpful to be done prior to surgery because in an ideal world, these are the patients that you can really help with a physiologic procedure. That is earlier stage lymphedema with somewhat patent lymphatic channels. Once you really start getting to stage 3 plus 4 and certainly 5, a lot of these physiologic procedures do not have the same amount of predictability as they otherwise would in an earlier stage. So now we can talk about some of the treatment options for these problems. And again, I'll highlight two basic treatment paradigms. One is prevention of lymphedema altogether, or lympha, and the other is really going to be used for treatment of lymphedema. So we'll first talk about lympha. Lympha stands for lymphatic microvascular preventative healing approach and was first coined by Campisi in 2008. It has since been termed immediate lymphatic reconstitution, or ILR, in 2017. And the concept is not really difficult to understand. Essentially, during an axillary dissection, these lymph nodes are removed, and the afferent lymphatics which drain them have nowhere to go anymore. And at the time of axillary dissection, what the surgeon can do is redirect these lymphatic channels into venules within the axilla, thereby creating a pathway for the lymphatic fluid to go instead of backing up into the arm. The patient selection for these procedures is typically a patient that is at high risk for developing lymphedema and is also undergoing an axillary node dissection. This is a procedure that's performed at the time of axillary node dissection. Ideally, the patient does not have neoadjuvant radiation, as this really makes the axilla very scarred, and finding potential targets becomes a lot more difficult. Additionally, these patients can't have any contraindications to a longer surgery, which would otherwise kind of preclude them from being a surgical candidate. The goals of lymphatic microvascular preventative healing approach are really to prevent lymphedema development. And the way it's performed really from a technical standpoint is the brachium is injected distally, approximately 5 centimeters proximal to where the ablative surgeon is making their axillary nodal approach. My preference is to inject isosulfan blue into the deep dermal and intradermal levels, approximately 5 centimeters proximally. I'll also inject ICG. Once the ablative surgeon is done performing their axillary node dissection, the axilla is examined with the microscope in the field. And the point here is really to identify some of these disruptive lymphatics. And the beauty of this procedure is that you really don't need a super high-powered microscope to do this. You can use a standard operating room microscope that you would be using for free flap reconstruction because the lymphatic tissue in the axilla is actually quite large. Using the isosulfan blue, you can identify some of these injured lymphatics, and at the same time, you can identify venules within the system. Once these are identified, you perform a lymphaticovenous anastomosis and confirm patency with ICG. Here's an example of a lymphatic venous anastomosis with the lymphatic the lymphatic tissue here, the anastomosis, and the axillary vein tributary here. You'll notice a competent valve right here. And this can be important because at times this system can be high pressure and therefore lead to back bleeding into the vein, which is or into the lymphatic venule, which is relatively lower pressure. So this competent valve prevents reflux into the lymphatic tissue. It's of note that this is actually a millimeter vessel at this level. So this isn't super microsurgery by any means. And here's another example of that anastomosis. So the This procedure has been around for about 12 years. We're still kind of accumulating data. Some of the older studies were relatively smaller patients with relatively short-term follow-up. Campisi described this in 2011, which was a trial of 46 patients and showed lymphedema rates at 4 versus 30% at 6 months. Rode did a similar trial with 37 patients and demonstrated lymphedema rates of 12 versus 50%. And lastly, Dhruv Singhal up here in Boston performed a meta-analysis and demonstrated that there was a reduced lymphedema incidence after axillary node dissection and with radiation, all the way down from 14% and 10 to 33%. But probably one of the better studies that's come out recently is this paper, which was published in Annals of Surgery about a year and a half ago. And this is a single surgeon experience from the University of Miami, where they had 380 patients. 300 patients essentially just went axillary node dissection without any lympha. 74 patients underwent lympha. And there was a decent amount of follow-up time of 15 months, which really, as we discussed before, is an adequate enough time to study these patients. And what they noted was that the lymphedema incidence decreased precipitously from 20% down to 3%. But probably even more important was that in this really high-risk cohort of patients who had over 22 lymph nodes removed, there were no incidents of lymphedema in this cohort, as opposed to 16 patients who otherwise did, or I'm sorry, 40 patients who otherwise did. So this is a really emerging therapy that can really help patients. It adds about another 3 hours of operative time to an axillary node dissection, and for really high-risk patients, can really benefit patients from developing lymphedema. The next thing we'll discuss is the treatment of lymphedema that already exists. There are many options out there, but the ones that we'll highlight today are going to be vascularized lymph node transfers. So a question I get whenever we discuss vascularized lymph node transfers, particularly to ablative surgical oncologists and medical oncologists, is how do these procedures work? Are we simply restoring missing anatomy? Do these vascularized lymph nodes act as a lymphatic pump, thereby pumping lymphatic fluid back into the system? Are there growth factors that encourage lymphangiogenesis, or is it simply unknown? And to be honest, we really don't know the full answer, but in order to study this, Mingwei Cheng developed a small animal model where vascularized lymph node transfers were performed in rats. In this, he had 18 groin vascularized lymph node transfers and 18 regular surgeries, just regular flap surgeries devoid of lymphatic tissue. And he injected ICG into 3 sites, into the flap, into the lymph node, into the surrounding skin. And what they noted, to summarize that study quickly, is that when ICG was injected into the flap, the ICG was taken up into the lymph node within that flap. And this eventually drained into the pedicle vein, thereby proving the concept that these flaps do in fact take up lymphatic fluid within the flap and drain them into the lymph node that's in the flap. They next injected ICG into the skin periphery and demonstrated that the vascularized lymph node actually uptakes some of that lymphatic fluid into the periphery, and this in turn drains into the pedicle vein, thereby making lymphatic fluid go from the interstitium all the way into the circulatory system. And lastly, when this was done without a lymph node in the flap, they demonstrated no uptake. And the conclusions were that these likely act, at least in a small animal model, like a lymphatic flap. These flaps make connections into the surrounding tissue. These lymph nodes then absorb lymph from the interstitium, and this drains directly into the pedicle vein. And in order for this to work, it likely requires a vascular supply, that is afferent and efferent vascular supply, i.e., you simply can't put non-vascularized lymph nodes into a wound bed and expect them to work. You really need this anastomosis. So there are many described sites for potential donor sites for vascularized lymph nodes. The 2 that we'll discuss today are going to be the inguinal lymph nodes and the intra-abdominal lymph nodes, both of which we perform here in Boston. To discuss inguinal lymph node transfer, it's important to highlight that these inguinal lymph nodes can be harvested at the same time as deep flap or free muscle-sparing tram flap harvest. The ideal patient for this procedure is an earlier stage lymphedema patient, as we previously discussed, who is otherwise an autologous tissue candidate. And again, has been compliant with at least 6 months of conservative therapy. And it's important to highlight this up front because many patients who will have any surgery will all of a sudden become very compliant with their conservative therapy. And if you see any difference in limb circumference or quality of life benefits, you really don't know if it's a result of their increased compliance or it's a result of the surgery that you just performed. So it's really important to have someone completely decongested and compliant with therapy prior to offering surgery. Contraindications to this procedure would be patients who are just otherwise not a great autologous tissue candidate, who are not compliant with therapy, have significant fibroadipose disease, if they have their thoracodorsal vein harvested, which we can discuss later, and otherwise would have a surgery that would preclude deep flap surgery. It's important to study the inguinal lymph node anatomy prior to offering these procedures because the surface anatomy can tell you a lot about the drainage patterns of lymph nodes in this region. The two primary anatomic landmarks are the groin crease and the inguinal ligament. Above the groin crease, these lymph nodes typically drain the abdomen. Below the groin crease, these lymph nodes typically drain the leg. It's really important not to harvest any lymph nodes which would potentially drain the leg, as this could lead to iatrogenic lower extremity lymphedema, which is a horrible consequence of this surgery. Here's a CT scan demonstrating these same landmarks, whereby the groin crease is highlighted here and the inguinal ligament is highlighted here. And as you can see here, lymph node 1 and lymph node 3 are above the groin crease and therefore very likely safe to take. However, lymph node 2 here is right at the level of the groin crease, and this is going to require some additional testing prior to harvesting this lymph node as to not cause iatrogenic lymphedema. This was also described by Hamdi, where he described the golden triangle area of lymph nodes to harvest. And in that, you have in between, again, the groin crease below the inguinal ligament, in between the SIA and V and SCIA and V. Here at Brigham, we use a technique which was popularized at Memorial Sloan Kettering, whereby we have 3 levels of assurance to avoid lower extremity lymphedema. The first is respecting the anatomic boundaries that we previously discussed. But then we have a positive and a negative control. The positive control is ICG evaluation of the lymph nodes. And in that, ICG is injected into the abdomen. And in real time, you can see lymph nodes in the groin, which highlight, demonstrating that these are the lymph nodes that are in fact draining the abdomen. A second level of assurance is provided with a negative control. In that, technetium is injected into the lower extremity, and when the lymph node flap is harvested, we use a Geiger probe to assure that there are no lymph nodes which highlight up in our lymphatic flap, because these would be lymph nodes that indeed drain the leg. So therefore, we have anatomic evaluation, we have a positive control that we're selecting lymph nodes that drain the abdomen, and we have a negative control ensuring that we're not taking any lymph nodes which drain the lower extremity. Here's a photo courtesy of Mark Chevrin demonstrating a bipedicled deep flap for unilateral reconstruction. As you can see, these lymph nodes can be harvested within the same incision with minimal donor site morbidity. And when inset is performed, here's the lymph node flap. These are placed into the axilla, and our bipedicled construct is anastomosed, antegrade, and retrograde here to provide breast reconstruction and at the same time provide lymphatic reconstruction. Instead of showing kind of individual summary results, I think some of the benefit of this technology, which has been around for a while, is we're now starting to develop meta-analyses of summaries of studies. In a pooled meta-analysis of 24 studies, the authors really tried to ascertain, why does somebody improve with lymphatic node transfer at the same time of deep flap? Is it simply providing soft tissue in this area, the deep flap alone, or did the lymph nodes play a role as well? And in this, they assessed subjective outcomes of patients who either had a deep flap alone or a deep flap with lymph nodes. And what they saw was that the deep flap with lymph nodes had approximately 84% subjective benefit, and the deep flap alone had a 22% subjective benefit. thereby demonstrating that it's likely the lymph nodes that are at play here. From an objective standpoint, these patients had 0 episodes of cellulitis afterwards. The average volume reduction was approximately 28%. 94% of patients reported range of motion improvement. 96% of patients reported soft, heavy feeling improvement. And 80% of patients had decreased sleeve compression after surgery. What's also important to note is with regards to donor site complications, again, the feared donor site lymphedema when taking the inguinal nodes, that it's quite low. And this actually predates our 3-step approach that was popularized at Memorial Sloan Kettering. And I would argue now these rates are probably even lower if all of these precautions are taken in advance. The last donor site that we'll discuss is taking intra-abdominal lymph nodes. In particular, the gastroepiploic or omental lymph nodes. This is an important source of lymphatic, drainage, as it can essentially be, harvested without any permanent scarring to the exterior body, and is relatively safe in patients who have abdomens that have not undergone significant amounts of surgery. But this is not a new technique by any means. Transporting omentum into the axilla to cure lymphedema has been proposed now for over 50 years. And in this case report, you can see probably why it fell out of favor back then, because here they described a pedicled omentum going transdiaphragmatically into the axilla. Clearly, this was an operation that was fraught with a lot of different complications and was abandoned shortly thereafter. However, these days, the omentum can be harvested either with a minimal incision around the umbilicus or laparoscopically, depending upon the size of the flap. The properties of the omentum are that it's the immunologic abdominal epicenter. It is rich in B cell production, IgM production. We know it's angiogenic with an abundance of VEGF. It has associated lymphoid tissue with multiple lymphatic lakes and multiple lymph nodes. But it's important to know where these lymph nodes are. And in doing so, Ketan Patel at USC has performed a very nice study using 3D reconstructed CT angiograms demonstrating the lymphatic anatomy of the omentum. And what they demonstrated was that most patients will have at least one lymph node in their omentum, and most patients actually have 2. This is a very large vascular pedicle with a luminal diameter of approximately 2.5 millimeters. This is also a very long vascular pedicle with approximately 20 centimeters of length. The majority of the lymph nodes are going to be located within the first 4 centimeters off of the epiploic. Therefore, the authors concluded, and at least in our practice, that an adequate vascularized lymph node transfer taken from the omentum is a flap that's approximately 3 centimeters in width and 9 centimeters in length. And here, we actually use a minimally invasive surgeon who's quite adept at doing this procedure. This takes approximately an hour to do. And he harvests this entire flap laparoscopically, thereby leaving a significant amount of omentum left in the abdomen. The ideal patient for somebody who's undergoing this procedure is, again, an earlier stage lymphedema patient who's compliant with therapy. Contraindications would be someone who's just not otherwise a good autologous tissue candidate, has significant fibroadipose disease, and has previous abdominal surgery, as this can make at least laparoscopic harvest much more unpredictable. Thoracodorsal vein harvest can be questioned as well, because that is our main target for this operation. And therefore, if we know in advance that that's injured, you should really start looking for bailout options in advance. Here's an example of the inset into thoracodorsal vein and artery. Again, a picture of the inset of the omentum into the axilla. And again, probably the group that has the most experience with this operation, which was first really popularized, at least in the literature, by Alex Nguyen, who was formerly at MD Anderson, Ed Chang, who still is there. And this is their paper from 2017, where they demonstrated a laparoscopic vascularized lymph node transfer in 42 patients with 14-month follow-up. And again, what we see is that cellulitis is greatly improved from pre to post-operative. Most patients endorse a significant amount of subjective benefit, and the average volume reduction is approximately 25%. So let's discuss briefly some of the future directions in lymphatic surgery and breast reconstruction in general. At least in the United States, there has been a significant emphasis on defining value in all surgery, particularly reconstructive surgery, as reconstructive surgery is very preference sensitive, and simply measuring complications doesn't tell us the real value of any procedure. Value is defined as quality over cost. Cost is pretty simple to figure out. It's the price of the operation and everything that goes along with it. But how does one define quality? Well, really, it's the clinical outcomes, as we discussed before, some of the complications, but it's a lot of the patient experience these days. And by that, I mean, would a patient recommend this procedure to a friend or to a family member? How do they feel about their treatment going forward? These are going to be very important things in breast reconstruction, in lymphatic reconstruction, and total hip arthroplasty, because again, complications don't really measure the full extent of what is important to the patient. And this is a very low bar to cross in lymphedema surgery because, let's face it, conservative treatment is the gold standard right now. And right now, as we discussed previously, it's costly, it's time consuming, it's relatively ineffective at halting progression, it's resource intensive, and patients really hate the therapy. As described here in these pictures, it's pretty brutal for many patients. So there has been an emphasis now on value-based care and on patient-reported outcome metrics, and this is really studied by our group here, led by Dr. Andrea Pusick at the Brigham Women's Patient-Reported Outcomes Value and Experience Center, whereby we have now developed a condition-specific patient-reported outcome measure for breast cancer-related upper extremity lymphedema in the LymphQ module. But this isn't just our group that's studying this. This was a systematic review published by Dr. Moreira at Memorial Sloan Kettering. And what they did was they just looked in the literature in the last 20 years and saw how many patients who have lymphedema are actually reporting on quality of life metrics. Because again, this is really important to patients. And what you see is up until about 5 years ago, nobody has really been talking about this, but about 5 years ago, there's been really an explosion of patient-reported outcome metrics that are being reported by patients and surgeons. And when we look at those, again, what you see is that the percent of patients who report subjective improvement with these therapies are exceptionally high for any surgery, 100%, 80%, 83%. And again, with some of these vascularized lymph node transfers using validated tools, again, you're seeing 91%, 100%, 84%. So this is going to be really important for patient education, but also with, providing, information to insurances. If you ever get any pushback regarding, reimbursement or validation of the therapy itself. So in conclusion, when providing some of these therapies, patient selection is paramount. Donor site lymphedema, and particularly these two donor sites, is exceptionally rare when performed correctly. The vast majority of patients will experience a subjective benefit. Most patients will decrease the size or duration of their compression, and some, particularly very earlier stage lymphedema patients, are able to be out of garments altogether. The vast majority of patients will experience significant improvements in quality of life, and we know that hospitalizations and infections will decrease precipitously. So with that, I'd like to thank you again for the invitation to speak today. This is my email address here at the bottom, and I'll take any questions if you have any. Thank you.
Thank you, Justin, for such a comprehensive presentation. Very enlightening. I would like to ask you the first question. When you were talking about lymphatic anastomosis, and we all know that there's a super microsurgery. We are dealing with vessels that are less than 1 millimeters. Do you think there are a group in the Netherlands, in Maastricht University, that they develop a robot? It's a robotic platform to perform super microsurgery, and the main advantages of this robot is that you can control the the tremor of the surgeon's hand. And do you think that this is really necessary? I think. Do you think that having a robot to perform a supper microsurgery is really helpful, or do you think that is not really necessary, and if you are an accomplished microsurgeon, you don't need it? Which is your opinion?
Probably I have a two-part answer. The first is I'm a big fan of technology and surgery. And certainly if there's something that makes surgery easier and more predictable, I would be willing to, kind of take a look. At the same time, it has to be cost effective. And anytime we add robots into surgery, we know that things become much more expensive, particularly as it relates to prostate cancer or some of the gynecologic malignancies. So that would be the first. If we're going to start, we have to measure it and make sure it's cost effective for the same outcome. The second point I would make is that at least for lympha, which is done at the time of axillary node dissection, these lymphatic vessels are actually quite big. As demonstrated, in some of the photographs that were shown, these lymphatic vessels can be over 1 millimeter in diameter. So this is, within the capacity of a plastic surgeon who otherwise does deep flaps or any kind of other free flap. These are not large vessels at that level. Typically, it's performed in an end-to-end anastomosis with 4 to 6 sutures. But if the vessel is big enough and there's a significant amount of mismatch, these can actually be intercepted on one another and just simply hooked together with a U-stitch, thereby really obviating a lot of the microsurgery involved. So what I would say is, at least for lympha, which is a procedure that can be done before lymphedema occurs, has a lot of evidence as to its benefits. I don't know if there's a role for a robot.
Thank you, Justin. By the way, I would like to take this opportunity to invite all the people that this Friday we are having our EGPS journal club, and Tom van Mulken from the Netherlands is presenting his experience on the use of this robot. So you are invited as well this Friday at 4 p.m. Argentina time. He's gonna talk about the journey of creating this platform. There are some other questions from the audience. The first one is regarding the lympha procedure. Have you detected any complication during the follow-up of the patient that have undergone this procedure?
Yeah, we have had, we really just implemented this program, relatively recently here in Boston. In the patients that we have offered it to, initially the thought was to not leave a drain in the axilla. It was not the preference of the majority of our surgical oncologists after a lymph node dissection, and I didn't want to leave a body in there that could potentially disrupt our anastomosis. What I found very quickly is that the seroma rate can be somewhat high, and as a result, we now place at least one drain at the time of lympha, and that complication has since gone away.
Wonderful. There is another, Dr. Shashank Lamba is asking about how do you decide how many LBAs needs to be done in lymphotherapy?
That's a really good question. And I think the answer is as many as you can do within a time constraint. The literature out there is somewhat inconsistent, but I think most people would prefer to do at least 2. In some of these studies, there have been improvements with as little as 1. Certainly 3 would be excellent. At some point, though, the surgery has to end. This is, an elective procedure done at the time of axillary node dissection. And so if you're reaching, 4 hours, 5 hours into surgery and you've done 2 or 3, I think the literature would validate that that's just fine. The majority of the anastomoses that were performed in the Annals of Surgery paper that I demonstrated, I think the average was about 2.2, indicating that there can be significant benefits with 2 or greater anastomoses performed.
Perfect. There is another question from Dr. Joseph Park. He says, thank you for your wonderful talk. And he is asking again, you already included this in your presentation, but anyway, what are your thoughts on BLBT and their efficacy?
What the thoughts? Thank you for the question. What are the thoughts of vascularized lymph node transfer and efficacy? I think, like so many of the preference-sensitive operations that we as plastic surgeons offer, it really involves having a conversation with the patient beforehand. If they have earlier stage lymphedema, you have to tell them that, this is a procedure that can be done at the same time as your breast reconstruction. If you have early stage lymphedema, what I can probably tell you is that if your infection risk will go down, practically to zero, you may be able to be out of a sleeve, certainly if you're earlier stage. But I can almost assure you that at least the compression amount that you're in can be decreased once these are fully engrafted. But probably the most significant benefit that I can tell you is that you will experience significant improvement in quality of life, particularly as the way the arm feels. It will feel lighter, your range of motion typically improves, etc. I would never promise anybody, though, that they could be, free of lymphedema and out of a sleeve completely. I think that's really important to tell patients up front.
Perfect. There is another question from Dr. Marlene Perez-Coleman. She says, thank you for the amazing talk. How does radiotherapy affect lymphatic axillary reconstruction? Do you clip the lymphatics that have been cut, but you don't anastomose?
Great question. So 2 things. Yes, all the lymphatic vessels which are not otherwise being used for anastomoses, we try to, clip them. With regards to radiotherapy, adjuvant radiotherapy, if we look at the studies, what we see is that the rates of lymphedema are still higher, unfortunately. However, they're still significantly less if lympha is performed versus when it's not performed. I believe in the meta-analysis that was presented, that number goes from lymphedema rates of 3% if there is no radiotherapy to 10% if there is radiotherapy and lympha is performed. So still significantly less than the 33% that would otherwise occur if you did not perform lympha, but still somewhat present.
Thank you, Justin. We have another question from one of our senior residents, Robertino Basso. He says, thank you, Dr. Broyles. What is your opinion about the role of prophylactic vascularized lymph node transplantation in those patients at high risk of developing lymphedema?
I think this is a great question, and it's something that we're beginning to look at as well. It's a great question because the normal sequence of seeing patients, at least in our practice, is mastectomy, tissue expander placement, radiation, and then 6 months later, we perform definitive autologous reconstruction. That's kind of how we, kind of platform patients through the reconstructive process. Now, you're going to have patients there that are at high risk for developing lymphedema. They've had radiation, they've had axillary dissection, maybe they're obese, but maybe at 6 months when they get their definitive reconstruction, they haven't yet developed lymphedema. So the question is, do you take lymph nodes at the time of their deep flap? Because you're already there, it's not a lot of additional surgery, and you could, potentially prevent them from developing lymphedema later on. It's a good question. I would be in favor of at least having that discussion we have not offered that surgery yet, but it's been something that's been a discussion amongst members in our group.
Great. There is another question from our microsurgeon from my department. There's Ignacio Piedrabuena, and he's asking is there any study comparing LVA lympha versus BLNT as preventive lymphedema surgery techniques?
I think, so one thing that I didn't talk a lot about today was lymphovenous anastomosis. We talked about lympha, which is done before lymphedema, but there's also lymphovenous anastomosis that can be performed for the treatment of lymphedema. It's not something that currently we offer a lot of at the moment. And the reason being is kind of twofold. One, it's really for really early stage lymphedema patients because they have to have patent lymphatic channels. And two, for some of these distal bypasses, you have to have a very high-powered microscope many times. And that's currently not something that we have at our hospital. So in order to kind of answer your question, I think, prevention of lymphedema is always going to be your best bet. So if you have someone high risk, you should really kind of consider offering them lympha at the time of VAX dissection. If they already have lymphedema, you can consider lymphovenous anastomosis or vascularized lymph node transfer or both. It's I think pretty well established in the literature that vascularized lymph node transfers typically are a little bit more durable and better at decreasing the amount of lymphedema, particularly in established lymphedema patients, as opposed to bypass. But certainly if there are targets, I would consider doing that at the time of transplant as well.
Thank you, Justin. Well, we have just 5 minutes left, and we have in the audience one of the plastic surgeons in Latin America with more experience in lymphatic surgery. He's Dr. Pedro Ciudad from Peru.
Okay.
We spent over 7 years in Taiwan with Professor Kun-Chin Chen. So Pedro would like to ask you something about Pedro.
Of course. Thank you, Horacio. Thank you very much for the great talk, Dr. Broyles. I have some comments instead of questions. Did you perform simultaneous breast reconstruction and lymphedema reconstruction with the DF flap and the gastroepiploic lymph node?
Do we do it concurrently? Yes. We offer the reconstruction of the breast and the lymph node transfer at the same time. Is that
with the gastroepiploic?
I'm sorry, what was that?
With the gastroepiploic lymph node flap.
Yes, we do.
No, I mean simultaneously, because I described 1 or 2 years before a simultaneous breast and lymphedema reconstruction with the DF flap and the gastroepiploid at the same time.
Oh, this with the omentum at the same time. No, we don't.
Okay. Yeah, I should clarify something because there is a little confusing about the omentum and the gastroepiploid. So the omentum is the entire omentum, and the gastroepiploid is the flap that we have described for probably 7 years ago. The gastroepiploid is a piece of omentum with like 3 centimeters width, maybe probably 6 or 7 centimeters long. So there is a little bit difference between the gastroepiploid with the omentum flap. So that's why maybe in 2015 we described this flap, the gastroepiploid, with our group in Taiwan with Han-Chi Chen. So I think this flap has a lot of benefits in compared with the entire omentum. The entire omentum has probably in the past a lot of scar tissue. So it depends also of the choice of the surgeons. But the other comment is that I always try to persuade the patients who undergo physiotherapy, complex decongestive therapy. Are you doing this also in your hospital?
Yes, so I agree with you completely on the omentum comment, and thank you for your work in that. Taking the entire omentum is probably not required. The majority of the lymph nodes, as you've described, are really kind of right along the pedicle, and the entire omentum can actually sometimes be too big to transplant up there. So I definitely agree with you on that, and thank you for the comment. The second, I believe, was regarding therapy, and we definitely, prehabilitate all of our patients to be really compliant with therapy 6 months before we offer surgery. And after surgery, they remain in therapy, both for outcome assessment and for just kind of meticulous skin care and ongoing treatment.
How long post-operative the patients are still with conservative therapy?
Most of our patients continue to see them for life.
I see. Okay, no, I think that that's always a great talk.
Thank you very much.
It's a great talk. Thank you very much. Thank you, Horacio, for the opportunity to participate.
No, thank you, Pedro, for being here. Well, I think we have time for one last question from Dr. Juan Larson. Dr. Larson wants to know if you participate in the lymph node dissection, while the breast surgeon is working in the axilla, and if does it make it easier for the rest of the lymph procedure?
Absolutely. So particularly when we started doing this procedure, which was our surgeons did not fully understand what we were doing, to be frank. I was there from the very beginning. So I would inject the isosulfan blue prior to starting the axillary dissection, and I would stay with the surgeon and say, kind of identify large lymphatic channels that they would otherwise cauterize and request that they clip them. Our surgeons were pretty quick. It only takes about an hour for them to do this procedure, so it doesn't add a lot of stress onto my day. But I find that the dissection is done a little bit more meticulously if I'm present.
Yeah. Well, the same happened with the mastectomy flaps, in saving the subcutaneous tissue and the fat tissue. And we have time for one last more question from Dr. Perez Coleman, that she wants to know if in patients whose lymphedema doesn't respond to CDT, is there any benefit to doing a BLNT?
I think, again, that it really depends upon the stage. So if somebody has, lymphedema that's otherwise, from a radiographic study, they have some amount of, patent lymphatic tissue present, I think they could definitely benefit from this procedure. The patients that probably don't benefit from some of the physiologic procedures that we described are going to be late stage or end stage patients. And again, that's why it's really important to kind of make sure that you know exactly what you're dealing with before you offer surgery. Is this simply lipedema, or is this actually lymphedema? Does it compress at all? Are there patent vascular channels? If somebody is, again, stage kind of 0 to 3, they can probably benefit. But for some of the later stage patients probably are not going to be the best candidates, and you have to really temper their expectations.
Wonderful. Well, I think that it's been a very productive morning, and I would like, I think that we all learned a lot about lymphatic surgery. And I think that this is a very exciting field in plastic surgery, and we're looking forward to see new techniques arising in this amazing field. Thank you, Justin, Dr. Broyles, for this wonderful presentation, and we really hope to have a new opportunity to have you participating in our conference, or perhaps visiting our hospital. We are planning to launch a program on lymphatic surgery, and it would be great if you can visit us in the near future once the pandemic is over. Please send my kind regards to Dennis Orgila and Andrea Pusick, and again, thank you.
Thank you very much. It was an honor. I'd love to see you guys in person. Have a nice day.
Have a nice day, everyone. Bye-bye.